Let's start with a very important topic, that is lower limb trauma. All right. So without wasting any time further, the first most importantly asked topic as far as your emergency procedure is concerned, that is dislocation of the hip joint. Now, what do you mean by the term dislocation of the hip? Simple is that hip joint is made up of acetabulum and head of the femur, and if the head of the femur is out of the acetabular cavity because of traumatic or any other reason, then it is considered to be a dislocation of the hip joint. Now, dislocation of hip can be of multiple varieties. But what you have to remember is the most common type, that is posterior type. Then the second one is anterior type. And the third one is central type. Now, as far as the three types of dislocation of the hip joint is concerned, although there are other variations also, all right, there could be a combination also, but what for your examination you have to remember is the posterior, the most common type, the anterior, and the central type. Now let's have a discussion of the posterior dislocation of the hip, because that is the most common type of the dislocation of the hip joint. Now, posterior dislocation of the hip, point number one is the mechanism of injury. The mechanism is a dashboard injury. What do you mean by the term dashboard injury? That imagine you are riding as a front passenger in the car, and there are sudden application of brakes. Because of this sudden application, then what will happen? The knee will strike against the dashboard. So the force which you are transmitting to the dashboard, the knee will be subjected to equal and opposite force from the dashboard to the knee joint. As a result of which, this force will be traversing from the knee to the thigh, from the shaft of the femur to the hip joint, and it will thrust the hip joint to move posteriorly. So it will result in that thrust, it will result in posterior dislocation of the hip joint. So this is dashboard injury. As far as most common nerve injury is concerned, it is not very difficult to understand that the largest peripheral nerve of the human body, that is sciatic nerve, is running just posterior to the hip joint, and the posterior dislocation might result in the impingement of this nerve. So the most common nerve injury is a sciatic nerve. Third point is most common associated fracture. It is also not very difficult to understand that if this is the acetabulum and this is the head of the femur, if the patient is subjected to a posterior dislocation, then with this posterior dislocation, there could be a thrust onto the posterior wall of the acetabulum. And this posterior acetabular wall fracture might be associated with this dislocation of the hip joint. So the most common fracture associated with the posterior dislocation is the posterior acetabular wall fracture. All right. As far as classification of this posterior dislocation of the hip joint is concerned, it is important to remember the name as well as different types of the classification of this posterior dislocation of the hip. So the name is Thompson-Epstein classification. All right. The posterior dislocation of the hip joint is such a common topic that its classification is also important for you to remember. Thompson-Epstein system of classification. Now, what you have to do in Thompson-Epstein classification, actually, it is classifying the posterior dislocation of the hip joint into 5 types. So the type 1 is when there is a posterior dislocation of the hip joint with either no fracture, means there could be a no fracture in any of the associated bone, or if there is a fracture, then it is only a chip fracture of the posterior acetabular wall, or only a small segment of the posterior acetabular wall is fractured. So chip fracture of posterior acetabular wall. So this is type 1. Now type 2 is the posterior dislocation of the hip joint, but it is associated with the large fragment fracture. A large fragment of the posterior acetabular wall is fractured. So large fragment fracture of posterior acetabular wall. Then type 3 is a posterior dislocation with comminuted fracture of the posterior acetabular wall. Now in this case, what is happening? That it is not only a fracture which is leading to a fragment, it is leading to multiple fragments, which is very difficult to fix it, all right, in its normal anatomical contour or position. Then as far as type 4th is concerned, it is the posterior dislocation plus the fracture in the floor of the acetabulum. That means the weight bearing surface of the acetabulum is also fractured along with the posterior dislocation. So floor of the acetabulum or the weight bearing surface of the acetabulum is fractured along with the posterior dislocation. And finally, the type 5th is posterior dislocation along with either the fracture in the neck or in the head of femur. The fracture in the neck of femur or head of femur. So it is going to be type 5th. Now, if you move down the table, there will be a worsening of prognosis. You see, in type 1, what is happening? There is a pure posterior dislocation of the hip joint only without any fracture, or if at all there is a fracture, it is only a chip fracture which is needed, where there is no need to fix this kind of a chip. All right. So what you have to do is just to reduce the hip joint. So type 1 would be having the best prognostic outcome. But when you move to type 2, when there is a large fragment of the posterior acetabular wall which is fractured, it is needed to be fixed. Type 3 is when there is a comminuted fracture, then with the fixation also, best results cannot be obtained. With type 4, there is further worsening of the prognosis because this time we are having the weight bearing surface of the acetabular wall fractured. And finally, type 5th would be having the worst prognostic outcome because in type 5th, the possibility of avascular necrosis head of the femur will always be there, or the possibility of having AVN is increased multiple times in case the patient is having a posterior dislocation along with the fracture neck of femur or head of femur. All right. So this is what the Thompson-Epstein system of classification is. So what all we have discussed, the first one is the mechanism of injury, the most common nerve injury, the most common associated fracture, and the classification. Then fifth point is considered to be the most important point as far as this type of dislocation is concerned. And that point is that what will be the attitude of the patient presenting with this posterior dislocation of the hip. The attitude will be that of the flexion, adduction, and internal rotation. That means the attitude or the abnormal position of the limb, abnormal position of the thigh would be that imagine the patient coming to you in the emergency after sustaining this posterior dislocation of the hip joint. Now, how the patient would be lying on couch is that the hip joint or the thigh would be kept in flexion, it will be kept in adduction, and it will be kept in internal rotation. So flexion, adduction, and internal rotation of the affected limb is a representative sign of posterior dislocation of the hip joint. It is considered to be a diagnostic clinical finding for posterior dislocation of the hip. All right, flexion, adduction, internal rotation of the thigh. And finally comes the management part. That means what you have to do in the form of a management. You see, most of the time when there is a pure or isolated dislocation of the hip joint, it has to be managed in emergency. So in emergency, what you have to do is a closed reduction. What you have to perform is a closed reduction. Now, for that closed reduction, you just have to flex the thigh to 90 degree and pull it into, by flexing the thigh into 90 degree, stabilizing the leg and the knee joint, you just have to pull it. So majority of the time what happens is posterior dislocation is getting corrected. All right. When it is adequately relaxed, when the muscles around the hip joints are adequately relaxed. And after achieving this closed reduction, it has to be immobilized, or the patient has to be immobilized for a certain duration of time. So that is the management protocol. But what was important for you to remember in this posterior dislocation, the most important part is the attitude. Thompson-Epstein system of classification we have just discussed because it is an important topic. So one way or the other, the patient, the examiner can ask anything in relation to this classification. The most common nerve injury, most common associated fracture is something which they are asking repeatedly. The mechanism of injury is exceedingly important. As far as management is concerned, you need not to open it most of the time. You just have to treat it in the emergency itself by flexing the knee joint and pulling it. If the muscles are adequately relaxed, then it will result in reduction of the hip joint. All right. So that is posterior dislocation of the hip. Now, how on the X-ray will it look like? As you can see that this is the acetabulum and this is the head of the femur, and the thigh seems to be adducted. That means when the head of the femur is out of the acetabular cavity, the thigh seems to be adducted. It is probably the posterior dislocation of the hip joint. Now, what is the reason for this attitude? What is the cause behind this kind of the attitude? Imagine this is the acetabulum, this is head of the femur, this is posterior dislocation we are talking about. Because of the anteversion of the acetabulum and because of the anteversion of the head of the femur, so majority of the time what happens that these two bony fragments, they impinge on each other, as a result of which there is no medial migration of the head of the femur. So head of the femur remains lateral. All right, when it remains lateral, the medial musculature will be contracting, leading to adduction of the thigh. When it goes posterior, the anterior musculature will be contracting, lifting the thigh into flexion in order to relieve pain. Point number 3, when it is posteriorly dislocated, the anterior rotators, which are internal rotators, it will be more stretched, and because of more stretching, there will be more rebound contraction, and because of this more rebound contraction, it will pull the thigh into internal rotation. So flexion, adduction and internal rotation is the attitude for posterior dislocation of the hip joint. One more thing which is exceedingly important for you to remember over here is that, you know, when the head of the femur is out of the acetabular cavity, the head of the femur is no more supported by the floor of the acetabulum, as a result of which it will migrate proximally, and this proximal migration will result in the shortening of the limb. So there will be a true shortening of the affected limb. One of the very important clinical sign that you have to remember associated with this posterior dislocation is the true shortening of the limb. So these are the clinical features which you need to remember. Flexion, adduction, internal rotation of the thigh associated with the true shortening of the limb are the clinical feature for posterior dislocation of the hip joint. Now, next topic is anterior dislocation of the hip. You know, anterior dislocation of the hip discussion is in context with the posterior dislocation of the hip, in comparison to the posterior dislocation of the hip. So what you need to remember, point number 1 is the hint in the question. You see, if the examiner decides to give you a question because of dislocation or a question out of this topic dislocation, and they are giving you a elderly age group, you know, majority of the time what happens that posterior dislocation is the most common type of dislocation. So majority of the questions are going to be asked from posterior dislocation of the hip joint, and it becomes a habit of a student to mark the answer as posterior dislocation of the hip. But in case if the age provided to you is that of elderly, because you know, in case of elderly, anterior dislocation also can happen. All right, it's not like that in case of elderly, anterior dislocation is more common. No, but if at all anterior dislocation has to happen, it is more common in elderly. So this is how you need to remember the statements. So if the age group provided to you is that of elderly, then just marking the blunt answer related to posterior dislocation, think twice before marking the correct answer. Now that thinking would be based on the attitude, means how the patient will be presenting to you when he is placed on a couch in the emergency after sustaining this anterior dislocation of the hip joint. Here, the attitude of the thigh would be that it is kept in abduction and external rotation of thigh. The thigh would be kept in abduction and external rotation. Now, what is the important, what are the factors which are responsible for this abduction and external rotation? You know, this is anterior dislocation this time. And as I told you, the acetabulum is anteverted, so is the femoral head, as a result of which this anterior dislocation will result in medial migration. When the head is medial migration, it will act as a fulcrum. The thigh will act as a fulcrum, thereby lifting the thigh into abduction. So it will be lifted into slight amount of abduction. And when it is anteriorly dislocated, the posterior rotators will be more rebound contracted. There will be a more rebound contraction of the posterior, which are external rotators. So it will lift the thigh into, it will rotate the thigh into external or lateral rotation. All right. So abduction and external rotation is the key attitude for anterior dislocation of the hip joint. And if you compare with the posterior dislocation, there was flexion, adduction, internal rotation. Here it is abduction and external rotation of the thigh. Then in case of posterior dislocation of the hip, there was a true shortening of the limb because the head of the femur migrated proximally. In case of anterior dislocation of the hip also, the head is out of the acetabular cavity, which is no more supported by the floor of the acetabulum. So there has to be a proximal migration. But the presence of the rectus femoris